So, chapter 17, cardiology. It's 101 slides, and we're going to power right on through it. Okay? We're going to review the circulatory system anatomy, physiology, pathophysiology, cardiac compromise, acute coronary syndrome. We're going to talk about nitroglycerin. All right? We're going to talk about age-related variations, pediatric versus geriatrics, and assessment and care. All right. EMTs Ella and Lisa are caring for Bart, a 62-year-old man with a history of angina. Mr. Frey experiences an onset of a heavy pressure in the center of his chest. Radiating to his left shoulder. I got it, homie. I'm good. Thank you, though. Heavy pressure in the center of his chest. It radiates to his left shoulder and accompanied by profuse sweating. Ella's general impression is of an alert but anxious patient who appears pale, diaphoretic, and whose facial expression indicates distress. So what do you think may be some of the underlying processes that leads to angina? What is angina, first of all? You might know? Okay. Knowing what we know about the body and how much we depend on oxygen, do you think maybe angina is like the heart telling you that it needs more oxygen?
Yeah.
You think so?
Yeah, we'll go with that.
Okay. Is the patient's presentation consistent with angina, or do you suspect something else? It can be a lot of different. It can be a lot of different things. Okay. What additional information do Ella and Lisa need as they begin patient care? All right. So, heart disease is America's #1 killer. It can lead to chest discomfort or cardiac arrest. Because of the potential consequences, we as EMTs treat all patients with signs and symptoms of cardiac compromise as a cardiac emergency. Okay. When you get into more an advanced setting and field, you can differentiate whether it's a cardiac emergency or not. All right. The circulatory system has 3 major components. You have the heart, which is your pump. You have your blood vessels, which is your pipe. And you have your blood, which is your fluid that's being carried around. Everybody make a shift for today? Good. All right. The conduction system. The heart has the property of automaticity. Okay? Means it conducts its own electrical impulse. It's automatic, and automatically conductive, and contractility. The primary pacemaker of the heart is what we call the SA node, the sinoatrial node. The AV node, or the atrioventricular node, all right, and fibers in the ventricles can both generate impulses automatically if that sinoatrial node fails. Okay. So the body is pretty freaking amazing. It's got a backup for a backup for a backup. Okay. Impulses generated by the pacemaker travel along a conduction pathway so that the impulses reach the individual muscle cells of the heart. All right, and these are those Purkinje fibers. The heart's electrical impulses travel through the heart from the pacemaker site by a conduction pathway that is composed of cells that neither initiate an impulse nor contract. These cells of the conduction pathway rapidly conduct each impulse to the rest of the heart muscle. They do this in a unified fashion so that rather than the whole heart contracting at once, there is a sequential contraction of the chambers. All right, your atria is going to beat, then your ventricles are going to beat. All right. The heart's activity is monitored by the body to ensure that it is meeting the body's blood flow requirements. The heart's activity needs to be modified. Assistance is provided by the autonomic nervous system. Okay? All right, the right side of the heart receives what? What kind? Oxygenated or deoxygenated?
Oxygenated.
No.
Deoxygenated.
Deoxygenated. The right side of the heart receives deoxygenated blood from the venous system and pumps it into the lungs for oxygenation. The left side of the heart receives oxygenated blood from the lungs and pumps it into the body. Okay? The pressure in the pulmonary vessels is low. Thus, the right ventricle does not need to generate a great deal of force to eject the blood. In some lung diseases, such as emphysema, however, the pulmonary vessels are compressed or narrowed. This increases the pressure in the pulmonary vessel and makes it much more difficult for the right ventricle to pump the blood out. If this high pressure is sustained over time, the right ventricle will begin to weaken and eventually fail. This is referred to as right-sided or right ventricular heart failure, or the medical term is cor pulmonale. The pressure in the aorta is high, therefore the left ventricle must generate a significant amount of force to eject blood against that pressure for it to go out into the body. All right. If the pressure in the aorta is excessively high, as seen in severe hypertensive patients, what does hypertensive mean?
Blood pressure's too high.
Blood pressure is high, okay? Or if the blood pressure is simply higher than normal over a long period of time, the left ventricle will begin to weaken and fail. Also, if the left ventricle muscle is damaged due to blockage of coronary artery, the ventricle weakens and can't pump an adequate amount of blood out of the left ventricle, and this leads to heart failure. This is left-sided heart failure. There are two different sides, okay? You have right-sided and you have left-sided. All right, the heart consists of 4 chambers. You have the atria and the ventricle. 2 atria, 2 ventricles. The heart has only one purpose, and that is
Pump blood.
Pump blood, all right? If that single purpose is interrupted even momentarily, cardiac arrest ensues and the chance of survival is slim. All right, arteries carry oxygenated blood to the arterioles, then to the capillaries, which interfaces with the cells throughout the body. The exception to the rule that arteries carry oxygenated blood is the pulmonary artery. Okay, and the pulmonary artery is the only artery in the body that carries deoxygenated blood. All right, it carries it from the right ventricle to the lungs to be oxygenated. Capillary walls are thin enough to allow the movement of gases, nutrients, and waste products between the blood and the tissue. The heart receives a constant supply of oxygenated blood it needs through the coronary arteries. All right, these are all your major arteries up here. Here's all your major veins. Okay, arteries carry blood away from the heart. Veins carry blood to the heart. Okay, arteries are oxygenated, veins are deoxygenated, except for which one? The pulmonary artery and the pulmonary vein. If a large coronary artery is blocked, it cannot supply an adequate amount of blood to the heart muscle. Eventually, if the occluded coronary artery isn't opened or unblocked, the heart muscle becomes hypoxic and begins to die. Okay? This is what happens when you have a heart attack. All right? The heart perfuses itself first with oxygenated blood before sending the oxygenated blood to the arteries and throughout the body. The coronary arteries are the first 2 arteries to originate off the aorta and are the same arteries that are associated with many cardiac emergencies. All right? You have a right coronary artery and a left coronary artery. Okay, the left coronary artery actually bifurcates, I believe. I think you have an ascending and a descending on the left. Okay, that's what actually, the left one is what feeds the ventricles. Okay. The blood is composed of several components that serve multiple functions for the body. The liquid portion of the blood, the serum, serves as the transport medium for formed elements. The formed elements include red blood cells, which, among other functions, carry oxygen to the tissue in the body. And it carries it on the what? The hemoglobin. All right, white blood cells serve to protect the body and eliminate infection from viruses or bacteria. Platelets are cellular elements whose job it is to help in the clotting process to stop the bleeding. The normal clotting mechanisms of the blood can form a clot in a coronary artery that is damaged by plaque. The clot may partially or completely occlude that coronary artery, results in cutting off or reducing the supply of oxygenated blood to the heart muscle. The heart muscle becomes deprived of oxygen and may eventually begin to die. Okay? All right. When the heart muscle becomes deprived of oxygen and it starts to die, okay? This can and will lead to a heart attack and subsequent heart failure or a serious cardiac rhythm disturbance. Okay? So exactly how does this start? All right, this is what we're calling arteriosclerosis. The innermost lining, the endothelium of the artery is damaged from the result of smoking, diabetes, high blood pressure, high cholesterol, or a number of any other causes, right? Fatty streaks begin to form in the damaged vessel walls, right? The body is always going to try to fix itself, right? These fibrous plaques form, and it causes further vessel damage and progressive resistance to blood flow. The plaque deposits begin to ulcerate and or rupture, and platelets aggregate and adhere, because that's what platelets do, okay? They're sticky, they stick to each other. That's what forms a scab, okay? That's what stops the bleeding, all right? And adhere to the surface of the ruptured plaque, and this forms clots, all right? These clots may be nearly or it can totally block the artery, all right? There's a really good picture of that in your book, if you can't see that screen right there, all right? A is what a normal, healthy, well, kind of sort of healthy, it's got a little plaque in there. But when you get to D, you're not getting any kind of blood flow, huh? Very, very reduced. All right, cardiac contraction. The right atrium at the SA node, okay, it's at the very top of the right atrium is where the SA node is. It travels through both the right and left atria by the way of the Bachmann bundle. Both atria contract simultaneously because of this electrical impulse. All right. The impulse then travels to the AV node by way of an internodal tract located between the atria and the ventricle. The impulse is inhibited briefly to allow blood from the contracted aorta to fill the ventricles. Then the impulse travels down the bundle to the left and right ventricles via the left and right bundle branches. Okay. From the bundles and the left and right bundle branches, the electrical impulse travels to the Purkinje fibers, which are embedded in the ventricular muscle, causing the ventricles to contract simultaneously. All right, electrical activity of the heart is represented on an EKG in a series of waves that correspond to electrical events in the heart. These waves or deflections of a normal EKG have three portions. You have a P wave, you have a QRS, and then you have a T wave. All right. I'm going to kind of talk about a little bit about what all this does. All right. Let me not write on the brand new screen, which is hot. I asked for about 8 months ago.
I remember going to that was quick.
No, it was actually 2 years ago that I asked for it.
Well, quick.
But however, anybody know where my marker went? I had this morning.
It's over here, is it green?
Yeah, probably so. Alright. Y'all probably won't be here, well, I hope you're not here next semester when we start going over cardiology with the paramedic students, but this is how it goes, okay? And there's probably a chart in your book to better illustrate this. And if you laugh at my drawing, I swear you'll fail, okay? Because I'm not Bob Ross.
Can't make it happen.
No, this is not gonna be a happy EKG, okay? It's gonna be a kind of cantankerous EKG. Alright, you have a P wave. That's a little big. See, I told you. You have a P wave, alright? Then you have your QRS, and you have your T wave. Everybody see that? That's, no, alright. This is your atria contracted, okay? This is a P wave. This, right here, right here, right here. This is a QRS. This is your ventricles, okay? This is your T wave, and this just means that it's repolarizing. Alright, so atria, ventricle, repolarizing. And you're gonna have that all the way across. Let's say you have, I can't really think of anything that.
Is that a 4-lead?
That's a 4-lead. Okay? This is just looking at one side of the heart. That's what a 4-lead does. It looks at one side of the heart. Alright? Just this triangle right here. Okay? The 12-lead, so 4-lead, it looks at this triangle. You put the white up here, black goes down here, and then green, red goes over here. Alright? West, Baton Rouge, and then you put the green one over here. Or white, black, red, and then some people remember it. Red is fire, so you put smoke over fire. And then the white one goes over here, and then the green one goes at the bottom. Some will not have this green lead, alright? I call it a green lead because, the color on it is green. But they'll actually have like, right arm, left leg, right leg, stuff like that, okay? A 12 lead will actually look, see if I can draw a board here, alright? It's gonna start up here, and it's gonna circle this whole thing, even around to the back, alright? And it takes a picture going this way, and then kind of looking around to the back side. And we can actually take some of these leads from the front side and put them on the back and get a more, it's called a 15 lead, that some places are actually doing now. Well, yeah. You can get a really good picture of the heart and stuff if you know what you're looking for. All right, let me put that out there. You have to know how to read them. All right, it takes a pretty good while to be confident in knowing what you're looking at. Because there's all kinds of cardiac abnormalities. Okay. But what we need to know here is that P wave is the atria, and the QRS is the ventricles, and the T wave represents repolarization, so that everything can happen again. All right. And this is pretty much what we just talked about. You have your P wave, it's your atria contracting. You have your QRS complex, which is your ventricles contracting. And then you have your T wave, which is the whole thing getting set up to do it again. All right? And any variation of these is a bad thing. Okay? And I'm telling you, there are a ton of things that can go wrong. You can have too long a distance between the P wave and the QRS. You can have a widened QRS. You can have a very narrow QRS. You can have an inverted P wave, inverted T wave. You can actually tell if somebody's had a heart attack before because there's damage there. There's a lot of things that you can tell from just, you can't tell it from a 4-lead, which is why a 12-lead is the gold standard now, okay? All right, the heart muscle can become hypoxic, be injured, or die. The electrical conduction system can also be damaged or disturbed and cause the improper functioning of the heart. Sometimes these conditions produce an irritability of the heart that causes the uncoordinated firing of electrical ventricular impulses called preventricular premature ventricular contractions, also called PVCs. When these PVCs occur in succession, they can produce ventricular tachycardia, which displays on an EKG as steep peaks and valleys that are close together. If left untreated, it can degenerate into VFib. All right, so let's talk about what VFib looks like. The VFib, you're not going to have any kind of discernible P wave, okay? So, here's your normal. You have a P, you have a QRS, and you have a T, right? This is what VFib looks like, okay?
It's pretty obvious.
Yeah, okay. This is what's known as coarse VFib. Then you can have some that's kind of like that, okay? It's fine VFib. Let's talk about a PVC. This is that premature ventricular contraction, all right? So you have your P wave, you got your QRS, you got your T, and then you're gonna have another QRS. But you don't have a P wave, the ventricles are firing on their own. And then what they're talking about, that ventricular tachycardia, it kind of just looks like that, okay? And they can have a pulse with this. That's why we don't ever put an AED on anybody that has a pulse, all right? Because if they don't have a pulse, this is shockable, all right? The other one we need to talk about is flat line. Anybody know what that is?
Yeah.
Yeah, they're dead. What's the name of the rhythm? It's called asystole. Okay. A means without, systole means contraction or ventricular beating. It's nothing. Right? Contrary to popular belief, Grey's Anatomy, ER, Chicago Med, all that good stuff, we do not shock this. It's not shockable. You have to have electricity to generate electricity.
It can be PEA.
You can have PEA. All right, let's talk about PEA. PEA looks just like this. You will have a normal rhythm. What you don't have is a pulse. You have the electricity going through the heart, but the heart is not pumping like it's supposed to. Okay, that is a non-shockable rhythm as well. All right, so this one gets electricity. This one gets electricity. This one has no pulse. It gets electricity. The rest of these, no electricity. Okay. I don't think we really get into it in the basic level, but there's different kinds of electricity. There's defibrillation, there's cardioversion, there's synchronized cardioversion. Like, you really have to know this stuff, or else you can seriously kill somebody. It's almost dead anyway. You can either save them or you can kill them. It's kind of 50-50. Okay. Cover my Bob Ross part up. That was a happy VFib.
Yeah, exactly.
Yeah. We had two kinds. We had happy VFib and kind of not so happy VFib. Yeah, I know. I love watching him. He makes me sleepy. Yeah. All right, the blood pressure is the amount of pressure exerted against the arterial wall during circulation. A smaller size vessel offers greater resistance, resulting in a higher pressure. So, vasoconstriction, which is constriction of the blood vessels, increases vessel resistance and blood pressure. The delivery of oxygen and nutrients from the blood through the thin capillary wall into the cell and the removal of carbon dioxide and other waste is known as perfusion. The chief result of inadequate circulation is a state of profound depression of cell perfusion called shock, or, as we know from our bleeding and shock control in lab, what is this also known as?
Hypoperfusion.
Hypoperfusion. Fantastic. All right, time is a critical element in the survival and improved outcome of many of these patients. Death of a portion of the heart muscle is permanent and irreversible. Okay? You know that part of your liver, like if you donate part of your liver, like a lobe of your liver will grow back. Alright, your heart, you only get one. Okay? And once it's damaged, that's pretty much it. Alright, it is important for us as EMTs to recognize the signs and symptoms of many possible cardiac conditions. Alright, we refer to this collectively as cardiac compromise. We have to provide emergency care and expeditious transport to a medical facility that is prepared to manage a patient with these conditions. Alright? Not every hospital will be able to manage some of these patients, okay? Some of these patients might be eligible for drugs such as fibrinolytics and antiplatelet agents, okay? If they have a clot in there, we can take them to an appropriate facility where they can give them medicine to bust that clot up, all right? Or they can do angioplasty, which is kind of like going in and grabbing the clot. Maybe they'll roto-root it. It's like calling the plumber for your toilet being backed up. Okay? They can also go in and put stents in to hold those arteries open. Okay? Those stents also have antiplatelet agents that will not allow the platelets to clog up those stents. Alright? And the sooner the patient receives treatment, the better the prognosis. Alright? Arteriosclerosis is a condition that causes the smallest of arterial structures to become stiff and less elastic. This is also referred to as hardening of the arteries. Arteriosclerosis. Alright? You have arterio, which is artery, and you have arterio, is a form of arteriosclerosis, all right, which leads to narrowing of the arteries and the reduction in blood flow to the heart. The inability to deliver increased blood flow to the myocardium when it is needed causes ischemia. Do anybody know what ischemia means? Starved of oxygen. Okay, that's what we call it when it's in the heart, ischemia. Okay. This ischemia, when the heart cells become ischemic, all right, they let you know by producing a pain in the chest. There's some other things, but this discomfort is called angina pectoris. All right. So the layman terms is chest pain. My chest hurts. All right. We know it as angina pectoris. Acute coronary syndrome is a significant disease and significant cause of death in the United States. Early recognition and signs and symptoms. Early recognitions of signs and symptoms and early intervention are the keys to reducing death from acute coronary syndrome. Acute coronary syndrome results from a variety of conditions that can affect the heart in which the coronary arteries are narrowed or occluded by fat deposits, okay, plaque, clots, or even spasms. The word acute and syndrome refers to the sudden onset of symptoms from coronary artery narrowing or occlusion. Chest discomfort or pain that is result of heart muscle ischemia is referred to as ischemic type chest pain. If you ask the patient if they have chest pain, they might answer no. All right. More often, the patient feels a crushing chest pressure that is described as dull or aching, or not as a pain. All right. It can be a pressure, a discomfort. Feels like something sitting on my chest. Okay. The pain or discomfort can be localized to the area of the sternum. That's why it's called substernal. It's below the sternum. It often radiates to the jaw, usually the left side, but it can go to the right side. All right. The arms, the shoulders, and the back. All right. Those are your typical, I'm having a heart attack thing, okay? I have chest pain. I have shortness of breath. Oh, your chest hurts? Does it go anywhere else? Well, yes, it goes to my jaw, my arm, my shoulder, and my back, all right? Females and diabetics and elderly patients, they will usually not give you these specific signs and symptoms. Females, elderly, diabetics, all right? They do not have this typical, my chest hurts. They can, but they usually don't, okay? It has been proven that females process pain different than men, okay? Also, with the geriatric population and the diabetics, okay? Diabetes does a number on your nerves, all right? So does getting older, all right? So they do not process this pain feeling. They may feel like they're going to throw up. They just don't feel good. I had a guy that I worked, when I was working in South Mississippi, picked him up at Walmart. His complaint was he had been burping. That was his only complaint. It's raining. And you will learn when you're in this field, you will get, you have 5 senses. You will get a 6th sense, okay? You're gonna you're gonna be able to walk into a room and be like, this person is sick or they're not sick. You may not be able to put your finger on it. You may not completely know what it is, but you can tell when something is wrong with somebody, okay? I happened to put him on the cardiac monitor just because of his age and everything, and he had what we call tombstones. That is a very, very bad sign, okay? He went straight to the heart center in Macomb, I believe. Anyways.
What are tombstones?
Tombstones are, I'll just tell you what it looks like.
Y'all let it take them far away than going to Mississippi.
Huh?
Y'all let it take them far going to Mississippi.
I live in Mississippi.
Oh, okay.
In Brookhaven. It'll look like your normal P wave and your QRS is gonna look like a tombstone. Like you can write his epitaph.
You might as well.
Yeah. It's a bad sign. Bad sign.
And he didn't feel any discomfort, he was just
No.
burping.
Because what does that show me about the contractions?
Too slow,
Or too long.
too big, too much water.
No. It's taking a long time to get where it's supposed to go. So this is your ventricles, right? What's the largest part of your heart? The ventricles. That's what pumps blood. That oxygenated blood, deoxygenated blood. That's what pumps it to your lungs, what pumps it out to your body.
So,
Okay?
would that affect blood pressure?
Oh yes.
Like blood?
Yes.
Have to?
Yes. Yes. Remember your preload, your afterload? You're not getting a whole lot out with this because that heart muscle is so weak.
So why? Because it stopped up or what?
Well, let's talk about this. Alright, here's your atria, ventricle. Alright, this is the biggest part. Then you have some coronary arteries that come around here. This one, the left side, actually breaks off and goes around the other side. And it feeds this whole ventricle right here. So he more than likely had a clot right there where this whole ventricle and the back side, this is what we call a widowmaker. Alright? So he probably had a clot right there where that ventricle was not getting the oxygen that it needed.
I'm just surprised you felt fine.
Yeah, I know, I was too.
I don't think it make any sense.
I know. But
Is it something that
he was elderly. I think
spontaneous?
maybe he was diabetic. No, this is something that it could be spontaneous. It could happen all of a sudden. But usually this is something that's built up. Now you can have a clot in the lungs that goes and then gets right here, and maybe that's too small for it to pass. But that whole ventricle is not functioning like it's supposed to anymore. And the only complaint he had was he was burping.
It
I'm
might
like-
have been taken a long time. He might have been feeling this for a long time. So.
It could have. It very well could have. Something you're going to learn is that most people are not very good historians. You can ask somebody, hey man, do you have any medical problems? No.
Okay, do you have this?
Okay.
Oh, yeah.
Do you take medicine every day for anything? Oh yeah, here's my bag. Here's my bag of medicine that I take every day. And it's like, well, you have medical problems then. Just because you take a pill for something does not mean you don't have it anymore. So you're gonna have to be very, very careful with how you say what you say and the information that you get back. Okay? And that's something that you will learn as you go out and you do these patient interviews and you start dealing with people and stuff like that. Okay? A complete blockage of blood flow through the coronary artery results in ischemia and death of myocardial cells. Myocardial ischemia can result in chest pain or discomfort. Rest to reduce the the heart's oxygen need, and nitroglycerin. We give this to relax the smooth muscle in the coronary arteries and dilate them. This will usually relieve angina. Okay? All right. Do you see that black part up here? Okay. And I don't know if it actually looks like this when they do an autopsy on somebody, but this is just for show. All right. You have a clot up here somewhere. All right. Let's say it's right here. Well, this whole artery right here, it's red, it's an artery. There's not any blood flow going down here, coming off here, right? All this is getting blood, that's good. This over here is good. But this right here is dead. It's dead, it's dying, okay? And we have to fix that, if at all possible, all right?
When it does,
You do not get it back. You can't regenerate a heart. Well, I don't know, that clone the sheep, I don't know why I can't clone a heart.
Put a pig.
Pig valve in,
Yeah,
a
pig
bovine.
Yeah.
I don't know that I can, that'd be weird. I just walk around like moving occasionally.
I was about to say,
Okay. There's two types of angina pectoris. Imagine that. It's not going to be just easy, right? You have two types. You have unstable angina. It has a variety of definitions, but it usually indicates angina discomfort that is prolonged and worsening, or that occurs without exertion and when the patient is at rest. Okay? That's why it's important for us to ask, what were you doing when this started? Oh, well, I just ran a 10-mile marathon. Okay, well, guess what? I'd probably be dead by now if I ran that far. But you're just having chest pain. You know, it's a lot different if they tell you they've run or been outside cutting grass or something like that, except for, you know, I was just sitting in my chair, my recliner with my feet propped up watching my stories. All right, I'm going to have a lot more level of concern for that person that's sitting in the recliner with their feet propped up watching their stories. Okay? So, characteristics of unstable angina can include pain or discomfort that occurs at rest, continues without relief, or is prolonged. All right? If the patient experiences angina that occurs at rest and lasts for more than 20 minutes, you have angina with a recent onset that is progressively worse, or angina that wakes the patient up at night. You should view this as an acute coronary syndrome emergency. Provide prompt treatment and transport. Okay? Stable angina is I was outside and I got a little too hot, cutting the grass. I came in, propped my feet up, and my pain went away. Okay? Or I came in, I sat down, propped my feet up, turned my stories on. I was still kind of hurting a little bit, so I went and took my nitroglycerin that my doctor prescribed. All right? Alright, classic angina is typically relieved with rest and nitroglycerin. If the classic angina following exertion isn't relieved after rest or after 3 nitroglycerin tablets or spray over a 10-minute period, you should recognize this as an acute coronary syndrome emergency and provide prompt treatment and transport. Alright, remember we talked about this earlier. Women, diabetics, and elderly may not have the typical presentation. A woman may tell you, my lower back hurts. Like that guy I picked up at Walmart. His problem was he was burping. I thought, well, that's weird to call an ambulance because you're burping. I mean, I pick people up for hiccups, so. Yeah, another day. Alright, administer supplemental oxygen if the patient is dyspneic, hypoxic, or hypoxemic, has obvious signs of heart failure. Okay, they have pink frothy sputum, swelling in their lower extremities, has an SpO2 of less than 94%, or the SpO2 is unknown. You need to initiate therapy by a nasal cannula at 2 liters per minute and titrate the concentration and liter flow to achieve and maintain 94% or better. Okay? What are we going to do for these people? If they have a prescribed nitroglycerin and their systolic blood pressure, which number is that? The top or the bottom? The top number. Okay, if their systolic blood pressure is greater than 90 millimeters of mercury, place them in a sitting or lying position and administer the nitroglycerin tablet or spray. We're going to talk about nitroglycerin here in a few minutes, okay? Another thing we want to do, if the patient is suspected of suffering from a coronary artery occlusion, administer 325 milligrams of aspirin if your local protocol allows. All right, aspirin, what we carry on the truck, is 324 milligrams. I don't know where this 325 comes from. It annoys me to no end. But however, you're going to give them 4 81 milligram baby aspirin. They need to chew it and swallow it. Okay? Some people say that aspirin is an antiplatelet. Some people say that aspirin is a blood thinner. The literature is different, okay? I believe it has properties of both. You also want to consider contacting advanced life support and be prepared to manage a cardiac arrest patient, okay? A myocardial infarction, or the severe narrowing of or complete obstruction of the coronary arteries, will result in death of myocardial cells if the blockage isn't quickly reversed. Ischemia and myocardial cells can result in potentially lethal dysrhythmias. Rarely, a heart attack can also occur from a spasm of the coronary artery. This can be caused by the use of sympathetic stimulating drugs such as cocaine. If the blood flow isn't restored to that portion of the heart, the cells begin to die. Ischemic heart tissue can become irritable. It can produce abnormal beats in the conduction system that could lead to dysrhythmias. Some dysrhythmias, such as ventricular fibrillation and ventricular tachycardia, can be fatal. Okay, if they're not treated, they can be fatal. If they're not treated right, they can be fatal. So, what are the most common signs and symptoms of an acute myocardial infarction? All right, number 1, chest pain, chest discomfort. Okay, they're usually going to be short of breath. Not always, but most of the time. Okay, they're going to have a radiating pain to their jaw, arm, shoulder, or neck. They're going to be anxious. Their body knows that something's going on, so it's kind of got them in this fight or flight mode, okay, which is actually bad because that's increasing their heart rate, which increases what? The oxygen demand of the heart, okay? That's what we're lacking right now, all right? They will have a sense of impending doom, okay? If somebody looks at you and tells you, I'm fixing to die, you better believe them, because they will die right there in front of you. I've seen it happen too many times. All right? So that sense of impending doom is a big, big thing. If that happens, listen, get somewhere. All right? They will be diaphoretic. What does that mean? Sweaty. Okay? They will complain of nausea and vomiting. Lightheaded, weakness, dizzy. Like we talked about before, the classic signs and symptoms of a myocardial infarction aren't present in all patients. Diabetics, the elderly, and women are more prone to atypical presentations. Many suffer a silent MI in which no chest discomfort is experienced. They might complain of shortness of breath, nausea, lightheadedness, or weakness. All right? Chest discomfort is the most significant symptom of a heart attack. The discomfort of the patient experiences is similar to that of angina. However, the symptoms last longer. It's also not relieved by the nitroglycerin. Also, chest discomfort from an acute myocardial infarction will only be partially relieved with the nitro or not relieved at all. All right? The boundaries between unstable angina and an acute myocardial infarction are not distinct. It can be very difficult to distinguish between these two conditions. Okay? So here's what Clay and I were talking about earlier. Especially here in the medical chapter, you're going to have a lot of things that have the same signs and symptoms. However, they will have a hallmark sign and symptom that will be different. All right? If I were you, and this is just my suggestion of being a paramedic for 20-something years, I would get me a note card. I would go through this book. I would write down AMI. All right? Chest pain, shortness of breath. Last longer than 10 minutes. Gray, pale color, nausea, weakness, dizziness, lightheaded. Nitroglycerin can be given incomplete or no relief. That's going to help you distinguish between angina. All right? They have this substernal chest pain. It goes to their jaw, arm, back, and shoulders. They describe it as dull or heavy discomfort. Usually lasts between 2 and 15 minutes. All right? Stopping physical activity, reducing stress, and nitroglycerin are factors of relief. Do you see the difference in those? Yes? No? Maybe? Okay. See where I'm going with that? All right, this patient has the potential to go in cardiac arrest. Therefore, you should frequently assess the patient and maintain a vigilant watch over their condition. The AED must always be available and close to the patient. Ensure a patent airway and provide positive pressure ventilation with oxygen connected to the device if breathing is inadequate. If breathing is adequate, administer supplemental oxygen if the patient is dyspneic, is hypoxemic, has obvious signs of heart failure, has an SpO2 of less than 94, or the SpO2 is unknown. You want to give oxygen therapy via nasal cannula and titrate the concentration in liter flow to achieve and maintain an SpO2 of 94% or greater. Place the patient in a position of comfort. If the patient has a prescription for nitroglycerin, administer 1 tablet every 3 to 5 minutes, up to a total of 3 tablets. However, you want to be sure the systolic blood pressure is above 90 milligrams of mercury and remains above 90 milligrams of mercury through that 15-minute time span. If your local protocol allows, yours does, you will give 324 milligrams of aspirin. You're going to give them 4 81 milligram baby aspirin, tell them to chew it and swallow it. You need to notify the receiving hospital early of a suspected MI. Continue assessment of the patient en route to the medical facility, and you want to consider contacting ALS for further assistance if available. Okay? So let's talk about why we wouldn't just blast this guy with oxygen. Why wouldn't we, if that's what his heart needs, why wouldn't we just blast him with oxygen? Why wouldn't we just breathe for him? Like, let's pump as much oxygen into him as he can get.
His SpO2 might already be around 98.
Okay?
If he's not getting the oxygen that he needs, you could, over-oxygenate. You could,
Oxygen toxicity.
Oxygen toxicity.
that's it.
Yes, love it.
But it would just be sitting there, it won't be.
Right. Here's the thing. Oxygen, too much oxygen, has been known to cause vasoconstriction. Okay? It makes the vessels and arteries constrict. Is that what we want right now? No, we do not. We want to open those vessels and veins up just as far as we can get them. Okay? Also, oxygen, too much oxygen releases free radicals. Alright? Free radicals are bad for your body, according to the research that I have done. Alright? Ella obtains a history from Mr. Frey as Lisa conducts a focused physical exam and takes baseline vital signs. Mr. Frey's discomfort came on 20 minutes ago while he was riding a stationary bike, but it was not relieved with rest or after taking a nitroglycerin tablet. He states the discomfort is a 7 on a scale from 1 to 10, and he says the sensation is worse than what he normally has with angina. Alright, his vital signs. Pulse 80, strong and regular. Blood pressure 132/84, respiration 16, SpO2 99%. So, what's going to be our first line of treatment for this dude? We're going to put a non-rebreather on him?
No.
Okay. What about an cannula?
No.
Okay.
He has enough oxygen.
He has enough oxygen. Alright.
He's already taken nitroglycerin.
Okay, he's already taken nitroglycerin. What does nitroglycerin do? If it dilates your arteries and your vessels, what do you think that does to your blood pressure?
Should go down.
It should go down, okay? So if he's already taken one, his blood pressure is 132/84, do you think it was probably higher, about the same, or lower than that?
Had to be
Probably
higher.
higher.
Okay, it's probably higher or about the same. It was definitely not lower, okay? What does that pulse of 80, strong and regular, tell you?
The heart's beating really strongly.
Okay. It's still pumping, right?
Strong.
Okay. So we still have something to work with here if we can get this stuff on board that we need to get on board, okay? And if we can get him to a cath lab or an advanced Band-Aid station. Like, I wouldn't take this guy to my hospital. I would take him to Glenwood, St. Francis, somewhere where they had a cath lab, okay? So what additional information is going to be helpful for the receiving hospital to know?
He's already taken nitroglycerin.
He's already taken nitroglycerin,
His vital signs.
his vital signs,
And past medical history if you can get it.
past medical history, right?
Because he said it's worse than his normal angina.
It's a possible,
It is a possible MI, and I like that you said that this is different than his normal angina, okay? That is a big, big thing. You can ask him, is this what it always feels like? Is this different? Okay? A lot of times you can get the information out of these people is knowing how to ask the question, alright? Okay, so let's take a little break here.